Hello and welcome to the MDS Podcast, the official podcast of the International Parkinson and Movement Disorder Society. I'm your host, Sarah Schaefer, and the deputy editor of this podcast. And today I have the pleasure of speaking to Professor Mark Edwards, who is a professor of neurology and interface disorders at the Department of Basic and Clinical Neuroscience, Institute of Psychiatry, Psychology, and Neuroscience at King's College London. And he also happens to be the winner of the Stanley Fahn Award lecture during the MDS International Congress in Hawaii this year, 2025. And today we're going to talk about what he's been musing about with regard to interface disorders, neurology, psychiatry, and all that goes along with that. So thank you so much for joining us and welcome.
Thanks very much. Thanks for having me.
And of course, congratulations on your award.
I'm extremely honored and grateful and still in a little bit of shock, to be honest. But yeah, it's a great honor to me to receive that award from the MDS.
Well deserved. You have been on our podcast a couple of times talking about various things. And you spoke in our June 2024 Hot Topic episode about the breakdown between pathology and phenotype. So how one pathology or one genotype can lead to multiple phenotypes, and how one phenotype may be explained by multiple pathologies. And then, of course, Mark Hallett pointed out in that episode that there's the black box of physiology in between, some of which we understand and some of which we do not. As much as we would like things to be clean, straight lines, they're usually not, is basically the long and short of it. So how does this line of thinking affect your approach to your patients and your work?
Well, I think it's part of really just a general recognition of complexity. And I think in order to do anything, you have to try and get rid of some of the complexity, because otherwise a problem is just too big. But I think sometimes that results in forgetting about the fact that actually you did do a lot of simplifying in order to answer the very narrow question that you then tried to answer. And that ends up producing problems, I think, in the way that we might interpret research results, or we might think about treatments for specific patients, test treatments, then try and implement them. And can result in a bit of frustration, I suppose, that in a clean, very controlled situation, you can get something to happen. And then when you put it into a more real world situation, it doesn't work like that. And I suppose one approach to that is to say we need to do the experiment again, we need to think more. But some of it is just that the way that things have been set up sets you up to fail a little bit in that way.
Definitely. So you're talking about science, right? Thinking about science and how we always want things to be nice and clean and crisp and wrapped up in a little bow. And we want to get rid of any confounder that we possibly can and exclude any patient that might make things a little bit more complicated. It sounds like you think that scientific inquiry might be approached a little bit differently.
Yeah, I think it's not an either or, because I think there is a benefit for really trying to simplify and define things and to control things very carefully. It's just you have to keep remembering that you've done that when you then try and extrapolate the results. And I think that's the thing that goes wrong. One can see it all the way through medicine in clinical trials. Definitely not the first person to say this, that randomized clinical trials are a fantastic tool, but they are done in a very well-defined, very controlled population. And so it's not surprising, therefore, that when you try and put that into practice in real life, sometimes the results just can't be replicated, or you get other results. We're seeing that recently in Alzheimer's disease trials, where the makeup of the populations in the trials, and this is quite common, tend to be from a higher socioeconomic group. They tend to have less ethnic diversity and so on. And so then you end up with results which can't be applied to a larger population. And I think that's also the case in more basic scientific research, particularly when you're involving patients, because we're defining patients often in a phenotype way. So if we say we're going to do a study on people with cervical dystonia, we get those people because we know what they look like, basically. And then maybe we get some results which are a bit difficult to interpret. Maybe at a group level, there's no effect of the intervention or the thing we're testing. But actually, it might be interesting to look beyond that and to see maybe there's individual clusters of patients within that And because maybe actually they've got a different underlying mechanism for their cervical dystonia compared to the next person, even though we lump them all together.
I think ataxia is a really good example of that. The older studies took all comers with ataxia, some including genetic ataxias, and maybe you throw some MSAC in there and see what happens with these medications. And then yeah, interpreting the results is so difficult. And that now that we're getting down into actual genetic diagnoses, so like SCOT27B, for example, we're finding that these smaller subsets of patients do respond really well to certain things, whereas other ataxia patients don't. Is that kind of what you're saying?
Exactly right. But at the same time, there's complexity there as well, because it depends what you're trying to do in the end. If you've got an intervention which is working at a low mechanistic level, then it's really important to do that clustering and to maybe get more isolated groups which have a particular mechanism. But there must also be a higher level where all of these patients converge on a higher mechanism that's producing the things that we can probably see in clinical practice, or maybe a small number of mechanisms. One example of that might be the use of deep brain stimulation surgery to treat tremor, where effectively, more or less, whatever kind of disease it is that's causing the tremor, you can put a lead in part of the thalamus and you can get a response. So that's telling you that there must be this higher level of a mechanism for the movement problem, which is active across multiple diseases. So that gets to this point that we need to investigate at multiple levels, but keep thinking about what we can achieve best at one level versus another.
You make me also think about Parkinsonism, and in my mind, sometimes I split people up into presynaptic Parkinsonism versus postsynaptic Parkinsonism. And those postsynaptic patients may respond to different medications, like dopamine agonists, for example, more than levodopa. If it's from some sort of subcortical insult, for example, it sounds like that might be another example. Do you think?
There is a value in understanding the mechanisms that are really close to the production of abnormal movement, the actual production of abnormal movement. So if you think about a complex degenerative disease, there's lots of changes that are happening in the nervous system or in the brain, for example, which may not be mechanistically connected to the production of abnormal movement. They're just part of the disease process. And when you do an investigation, you do some sort of study on the brain, you're picking up those things, but you may be picking up things which are actually mechanistically related to the movement problem itself. And it'd be nice to be able to separate them out a bit, because you could do something maybe quite specific if you knew exactly what was the mechanism of the movement problem itself. And that might be common across multiple underlying diseases. So it's this idea of having a kind of multi-layer look at things, rather than just saying, oh, we're going to investigate, I'll say, cervical dystonia again, and you just grab a group of patients with cervical dystonia, do some tests on them, and assume that everything that you found is mechanistically related to the production of abnormal movement itself, because it probably isn't.
Sounds like you're a splitter, not a lumper.
I'm both. So I think it just comes down to saying, what is the purpose that you're trying to achieve, and what is the level that you're investigating? And that allows you to shift between these different perspectives. And I think it's that gives you more insights. One can see that in this whole debate around the biological definition of Parkinson's disease, for example, and the recognition that within this thing we call Parkinson's disease, there are multiple disease processes. So there is a clear rationale for splitting in that way. But there's also a clear rationale, I think, for lumping together, not just from clinical services, but actually from a development of novel treatments point of view. Because if you can understand that higher level of how is this particular kind of abnormal movement being produced, you could do stuff about that, regardless of whether you change anything about the disease at all. So it's got that real therapeutic potential, which we can see is manifest in things like deep brain stimulation, for example.
I'm going to switch gears a little bit here to one of your favorite topics, FND or functional neurological disorders, which talk about complexity. That would be the common thread here. It's such an interesting case study when one thinks about how neurology and psychiatry divorced 150 years ago or whenever it was, and how we think of things in terms of this dichotomy between the two. It's one or it's the other. What has your exploration into FND taught you about the way the medical community approaches FND and other amorphous disorders? We could throw in chronic fatigue syndrome, fibromyalgia, dysautonomia, hypermobility disorders, these amorphous disorders that are not well understood. What are your thoughts on that?
Wow, it's a big topic and one which I've thought about a lot. I think, first of all, just fundamentally, I cannot see how one can be a successful clinician or researcher in the neurosciences without having an interest in psychiatric and psychological and psychosocial levels of behavior and function, because it's all in the brain. And if you've got a brain problem, it's likely to affect all of those dimensions. I think that good clinicians have always recognized that and have that holistic approach. But unfortunately, that's rarely facilitated within our clinical services, and it's rarely facilitated within research, where things tend to be split up into different things. I think one of the issues there is it's really hard to measure and therefore to value the complex interventions or complex management that people with disorders that cross over this barrier between neurology and psychiatry need. And that's most of our patients in neurology, particularly movement disorders, because the other stuff, which is not the sort of hard, measurable, objective stuff, feels very soft, and it's quite hard to characterize in the way that we got used to characterizing our interventions so from a neurological point of view. So it's therefore very easy to say that it doesn't really matter, or that it should be quite cheap, or it's easy. In fact, I think that's the hardest aspect of medicine, really. And I suppose my overall feeling is that this comes down in the end to complexity. So when you ramp up the complexity, that's where health services start to fall apart. And that's where health professionals get under increasing stress and strain. And that's where patients and families get a bad deal. And that's magnified or incredibly obvious in FND. So one of the main reasons why people with FND often get quite a bad deal is because of that complexity. But actually, that's true for multiple patients. And particularly within movement disorders, we regularly see people with high complexity. And I think if the listeners think of people where things have gone badly wrong, it's usually because of this complex relationship between neurological and psychological and psychosocial factors. That's brought me to this place in the end. I think making things better, so understanding F&D more, making better services, that's a good thing in its own right. I strongly believe that if we could really get that right for people with F&D, then that would help everybody with chronic complex illnesses, because the things that you need to do to get it right for people with F&D are the things that would benefit people with other conditions.
Yeah, with any chronic illness, your psychosocial dynamics impact your physical self and vice versa. So that needs to be recognized and addressed.
Absolutely. I think that something that's been made clear to me in seeing people with functional neurological disorder, where there's often this question about voluntary and involuntary, and how much is the person participating, helping the person understand their own illness, and so on. This loss of sense of agency that appears to be there in functional neurological disorder, and how do you give it back? That's taken me into this space that I wasn't in before, which is really fundamentally about rehabilitation. So a rehabilitation approach to medicine. And understanding that, you then see that how actually modern medicine takes that away, takes that agency away, often from people who are ill generally, and giving that back or facilitating that in the person and within their family unit is a massively important part of successful management of people with neurological conditions. And so you could see that in for example, in the use of exercise as a treatment for Parkinson's disease, and how if you instill from the very beginning that somebody's got this really frightening diagnosis, but look, there's something that you can do, you can put into place that can help with this, and that's your responsibility, but I'm going to help support you with that. That's a massively beneficial thing than this sort of passive situation of being told, oh, you've got Parkinson's disease, it's incurable, I'm going to give you some medicine, I'll see you in 6 months. It makes a massive difference. So I'm really enthusiastic about this rehabilitation model of management of neurological conditions. And that comes across really strongly in management of people with functional neurological disorder.
Absolutely. I agree with you that it is just so paramount to the treatment of patients with Parkinson's and other neurodegenerative or chronic conditions. I've definitely found that in my own practice.
I was going to say that also one thing about that idea of shifting to that rehabilitative model of medical practice where you're giving the person themselves agency is it does require the health professional, the doctor or another health professional, to have a degree of humility because you're effectively giving up some control. You're saying, actually, some of this is for you, and you're going to help me understand how best to treat your illness. That's not easy. And you also see it in the sort of relationship between doctors and allied health professionals and psychologists as well, where in order to work in that multidisciplinary way, again, you have to give up control. I think that sometimes things that are called multidisciplinary are really not. They're people working in silos in their own very strictly controlled bit of work. But true sort of interdisciplinary care does involve this, which it has to involve the patient as well, does involve this reduction in your own control as a health professional. And that's not easy. But I think when it works really well.
Not easy for all us type A personalities. So you're talking about multidisciplinary and interdisciplinary care, which is so important. And I mentioned the divorce of psychiatry and neurology that happened way back with Sigmund Freud and ultimately resulted in split specialties, split departments, split lines of research. Do you think that this institutional dynamic needs to change? And especially as we start having the ability to less expensively and only in experimental settings and more in clinical settings see what's physiologically happening on the psychiatric and psych neuro overlap functional side of things. How do you see the future as it relates to the care of patients with these diseases, some of which we may right now be able to explain well physiologically and some of which we can't? Do you think that neurology and psychiatry are going to ultimately come back together?
I really hope so. I think it's quite hard to do that. And I think there are reasons for specialization. Management of severe mental illness like schizophrenia, that demands some specialization. But even in that example, if you look at people with schizophrenia, they die on average 15 to 20 years earlier than they should. And not predominantly from suicide, but from treatable physical health problems like chronic airways disease, diabetes, heart disease, cancer. Human beings demand an integrated healthcare system, and we have to do something to make it better than it is at the moment. Because by splitting off into smaller and smaller bits, particularly this big divide between physical and mental health, we do people a massive disservice. That also requires, though, some change within the way that the sort of discourse happens within the public as well, because it's not just health professionals who are dualistic, it's everybody. And you can hear it all the time. For example, there was a recent paper published that was looking at genetic markers in people with chronic fatigue syndrome. And the reporting on the news was largely CFS is now shown to be a real condition because it's been found to have these genetic biomarkers. So that is a pervasive view out there. When you start to break it down, it's completely illogical And the people saying those things are really intelligent people, but there's just a blinkered way of thinking about what's real or not real. I think there's a danger of going the other way in functional neurological disorder and psychiatric disorders to say that, oh, now we found some brain biomarkers or there's this brain network dysfunction. That means that's the best way to talk about this problem. But that's stupid as well, because we know that people who develop functional neurological disorder have about 6 times the risk of having past traumatic experiences. Doesn't mean everyone has, but it's there. People with functional neurological disorder, often their symptoms are made worse by psychosocial stressors, and they often are in complex psychosocial situations, and there's high comorbidity with mental illness. So if you treat it just like a sort of brain network disorder, then you don't get any of that either. But again, I think it's about trying to understand that all of the disorders we're talking about are basically in this same space. If we understand that, then we understand that all of the people in this space need an integrated kind of approach to clinical services and to scientific research. And so it takes a little bit of the sting out of making FND some kind of weird or bizarre thing. It's actually just really very much the same as lots of other things as well. And we should just have the same general approach to that, just be normal.
This has been a really interesting and enlightening conversation. Thank you so much for sharing your thoughts, and I really look forward to your lecture in October.
Thank you very much. It's been a pleasure.
The views and opinions expressed by the participants in this podcast do not necessarily reflect those of the International Parkinson and Movement Disorder Society or their affiliated journals, Movement Disorders and Movement Disorders Clinical Practice. Any disclosures of the participants can be found within the episode description located on the MDS website.